Okay, so I'm going to go ahead and introduce Dr. Castro. We're very thankful that he is here with us today. Dr. Castro has a lot of accomplishments, so be ready to hear all of them. So Dr. Castro is a professor of medicine, vice chair for clinical and transitional research or translational research, Department of Medicine, chief division of pulmonary, critical care and sleep medicine at University of Kansas Medical Center, and director of Frontiers, University of Kansas Clinical and Translational Science Institute, and adjunct research professor at the University of Missouri, Kansas City School of Medicine. He has been a leader of the CDC controlling asthma in American cities, American Lung Association Airway Clinical Research Centers, and NHLBI Asthma Clinic Research Network, Severe Asthma Research Program, Asthma Net, and Precise Research Networks. His translational research projects in the Asthma and Airway Transitional Research Unit are focused on pathogenesis of asthma and treatment of asthma, especially in severe disease. Recently, Dr. Castro has spearheaded several initiatives to combat the COVID-19 pandemic, leading investigator for the NIAID funded COVID-19 prevention trials, Active 2 trial, and the HCQ trial. He is the author of over 30 chapters in books, over 300 peer-reviewed articles over the past 25 plus years. Dr. Castro has joined over 40 junior clinical and translational scholars. He is widely recognized as an expert clinician, an excellent mentor, and a skilled educator with a significant commitment to the development of young investigators' careers. So without further ado, Dr. Castro, you have the floor.
Thanks, Miranda. Can you hear me okay?
Yes, we can.
Great. Most importantly, I immigrated here from Cuba 50 years ago and grew up here in Kansas City. So I'm a Kansas City boy and went away for my training and have come back and excited to be part of KU and excited to be part of the community and especially was here for about 9 months and then the pandemic hit. So definitely had to get ready for that. So I'm going to need to be able to screen share to show the presentation. Evidently the host has disabled it. Miranda, are you?
Yeah, I say, Carla, do you know how to do that? Otherwise, Haid or anybody else who could assist us. I'm not really sure.
Give me 1 second. Check my.
Oh, here we go. I think I figured it out. Try it now.
Got it.
Yeah, works now.
Cool. Sweet.
All right. Well, I think over the next 15, 20 minutes, I'll try to get through this. But if you have any questions, feel free to shout them out as we go. And I know that some of you are familiar with KU, others are not. So it just want to make sure that you understand that we are under the umbrella of Frontiers. And this umbrella of Frontiers is a Clinical and Translational Science Institute, or CTSI, includes a lot of our university and academic medical center partners, including Children's Mercy, Kansas City University, K-State University, St. Luke's, and UMKC, and including our other KU campuses in Lawrence and Wichita. So, so hopefully we've covered our bases there, and certainly what I want to share with you today, though, is in particular information about the COVID-19 vaccine. What could you convey to your participants or patients that you work with? And then also a little bit of information about treatment and where we're going with treatment and some information there. First and foremost, we know, unfortunately, with this COVID-19 pandemic is that there's been a disproportionate effect on minorities, both racially and ethnically. So you can see here, and this was early on data, but it's kind of held true in terms of per 10,000 cases, the rate in Blacks is about 3 times those in white, and the rate in Latinos are almost 4 times that what we see in white. So this disproportionate effect is present for a lot of different reasons, at least for Latinx populations. Some of it's being driven by where we're working. We're in those frontline industries. Somebody wants to, okay. In those frontline industries, you all have heard about the meatpacking plants here in the state of Kansas that had basically COVID go right through it with hundreds of workers affected. We also know that Latinx populations live in crowded settings and multi-generational households. And because of that, COVID can enter a household and quickly spread throughout that household. It's not just the youngsters bringing it in. I had a patient the other day who caught it from his grandmother who brought it home, and then grandma, who was 80 some years old, spread it throughout the entire household to all the youngsters. So it happens both ways. And we also know often in Latinx households that there's disproportionate income, and a lot of that also drives having to work in these settings where you're pre-exposed to COVID. So a little bit about COVID first. So this virus, we've known a lot about coronaviruses, which is the family of this virus, for a number of years. In fact, coronavirus calls the common cold. There's a specific type of coronavirus that calls the common cold. And the one that we are focused on in this pandemic is a specific type of coronavirus, and we call it SARS-CoV-2. And this comes again from this family, and it has this unique spike protein. So you can see there on the center picture is a little numb that is surrounding that virus on this electron micrography of the virus itself. And because of that, for those that speak Spanish, corona is that crown, and that crown around there of that virus, that spike protein, is where the name comes from. So this spike protein has been, the structure of it was discovered end of January this past year, so just about a year ago. And this enabled us to start to leap forward with the science in terms of developing vaccine and treatments for this, because once you understand what the structure is of that virus protein, then you can start to develop the treatments, and we'll talk about that. So this spike protein is on the surface of the virus. And why is it important? Well, it's how it attaches to the inside of us. And so on our cells, in our nose and our respiratory passages, we express this receptor called the ACE2 receptor. And this is an important receptor for a variety of different reasons, but unfortunately, it's a way that the virus gets inside our cells. And so when vaccines were being developed, we target, because we knew the structure of that spike protein, the vaccines started to develop against that spike protein, because they knew if they were able to block this interaction with the receptor, then whenever the virus gets into your body, it can't go inside the cells and it can't do any damage. And so that's basically how the virus works. It interacts between that little spike protein and that receptor to get inside of the cell itself. And then right in the middle, you can see is, well, what if you develop antibodies, those little purple and green things, and those antibodies attach to that coronavirus protein, and it doesn't allow then the cell, it doesn't allow the cell to enter the body. And so you can see how that works. So I'm going to talk a little bit later about monoclonal antibodies that are given to a patient for treatment, but also when your body develops antibodies in response to the vaccine that we'll talk about, it's producing these antibodies that block that binding. So this is, again, something important, because I'll talk about, you know, how important this is in terms of conveying a message to your patients and participants. Now, this is a schematic of how the scientists have taken that gene from that spike protein. They basically took that and developed a purified form of that protein, injected it, not the live virus itself, injected that protein, and that prompted the immune system, your own natural immune system, to develop antibodies and these killer cells. And so in the bottom here, you can see the bottom here, you can see the antibodies then are developed. So when the virus enters your body again, all these antibodies are attacking that spike protein that we showed earlier. So this is what we're trying to do with the vaccine, is get your body to make these burgers, to make these antibodies to fight off an infection. Well, of course, you know, for you all that work with our community, this is where the benefit would come. It comes, of course, at the individual level, and that we could prevent infection, also perhaps prevent or reduce the severity of infection. In fact, people that have had prior infection with COVID-19, when they get re-exposed and if their antibodies have started to wane off, say after 6 months, when they get an infection, we know often the severity of that second infection is a lot less. And that's because those antibodies are lingering there and reduces that severity of illness. The other thing is that when we vaccinate the community, which we'll talk about, once you get to a certain level, that reduces transmission and allows us to get back to normality, right? And ultimately, that's what we need to do. And we need to get to that point so we can get back to our normal interactions on our individual level, on a social level, and at work as well. This has been really an amazing story of how these vaccines have been developed. Never in the history of medicine has a vaccine been this quickly developed. And in the US, that was guided by a cooperative effort through the federal government, through the NIH, through the Department of Defense, and that's called Operation Warp Speed. And you can see here a summary of that on a global basis. This was about a month ago. There were 43 vaccines being evaluated worldwide. 6 of those vaccines have really come to the forefront. 2 of those vaccines have been approved already under emergency use authorization. And of course, some of them won't make it. In fact, now that number, I think, has on the far right has changed to 2. There was recently one from one of the laboratories that did not make it. The 2 that are available right now are called the Pfizer BioNTech and the Moderna vaccines. And I'll talk a little bit more about that. But again, the main message here is that both of these vaccines require 2 injections. And if you get the Pfizer one, it's 21 days apart or 3 weeks apart. If you get the Moderna one, it's 28 days or 4 weeks. And again, we won't talk about the supply issues because that's an evolving story, including information we just got today from the State Department of Health and how they're distributing things. But it is the limiting factor really is the amount of doses that are available. So these are those 6 vaccines that I mentioned have made it to the forefront. The ones that are circled are the ones that we've been studying, both the Moderna and the AstraZeneca. The largest trial that we've been participating is the one, the AstraZeneca. The Moderna and the BioNTech are the ones that are currently approved under emergency use authorization. Those 2 are mRNA platforms, and they're pretty new. And we'll talk about some of the disadvantages of that, but the main disadvantage to those mRNA vaccines is that it requires ultra low freezers, temperatures. So -20 or -70 temperature. And because of that, it limits what we can do in the community. You can't just throw it in a cooler and take it out, because by the time you get to the center you're going or the home you're going in that cooler, it's going to be the mRNA becomes unstable and breaks down, and it no longer is effective. So you have to preserve that temperature, and that temperature maintenance is very carefully tracked and has to be carefully tracked. So you ensure that when you give that shot, you're giving mRNA that is effective in terms of stimulating that immune response. I'll talk a little bit about the vaccine trial that we just finished here, the AstraZeneca one. But you'll notice that both the AstraZeneca one and the Janssen one are adenovirus vectors, and we'll talk about what does that mean. The last 2 here are protein vaccines, Novavax and the Sanofi GSK one. And these are kind of the order of how things are coming out. Both the AstraZeneca one and the Janssen or Johnson & Johnson ones are supposed to be coming out next after the first 2. When exactly that will be, whether it be later in February or March, we don't know exactly the speed of that going through the FDA in terms of the review of the information. I can tell you from our own personal experience with AstraZeneca, we're still cleaning up the data. And so that's not going to be likely approved until March, based on our timeline right now. So I just want to tell a little bit of story of how we launched this trial here in Kansas City. And this emanated from colleagues of mine, Barbara Pahoud at Children's Mercy. She's a pediatric infectious disease colleague there, who's been involved with NIH studies there in their pediatric AIDS clinical trials network. And because this network existed when the COVID-19 prevention network, or what's called CoVPN, was developed by the Operation Warp Speed, they said, well, let's use places that we've already worked with. And so they reached out to Children's Mercy, and Children's Mercy then said, well, this is an adult trial. Let's partner with KU. And so we partnered together to roll out this AstraZeneca trial. This vaccine originated from Oxford University. It's called the ChAdOx vaccine. And then AstraZeneca bought it from them, but basically bought the rights of that vaccine to develop it and market it. And as noted on the top left, basically the adenovirus vector is shown here. And this is a very weak virus that infects a chimpanzee. It doesn't infect humans, and therefore you can use this virus to deliver things inside the body that you need to get into cells. And so that's exactly what they did, is they snipped off that protein, they sequenced it from the coronavirus spike, and they put it inside of that chimpanzee adenovirus vector. And that's called the ChAdOx 1 COVID-19 vaccine. We then can inject that adenovirus vector that has that spike protein inside of it into your arm. And when it does that, your body starts to produce antibodies to that spike protein. And that's what then prevents you from having infection when you get infected. So that's just how the ChAdOx vaccine works. So we conducted a study sponsored by the National Institutes of Health, the National Institutes of Allergy and Infectious Disease, and also funded by AstraZeneca that bought that vaccine. We aim to enroll 500 to 600 participants after we kind of realized what the amount of work was involved with this study. And as I mentioned, we were successful in enrolling 535 participants. And so we were right on spot on target. We did this unlike any other studies so far rolled at KU, is that we decided that in order to enrich our minority and ethnic populations and our rural populations, we needed to get beyond just doing it on the KU campus on Rainbow. So we went out to our Fairway campus, which is suburban Kansas City. We went to Wichita, KU campus, which is a rural campus. Of course, we partnered with KC Care, downtown KC. We partnered with Swope Health in Kansas City, Missouri. And then we also went out to Lee Summit, to TMC Lakewood, to utilize their extended care facility out there. And then lastly, we partnered with Health Partners Clinic in Olathe, which had we knew a large Latinx population. We were fortunate to get that van that's in the picture there. That van allowed us to take our show on the road. So those 3 sites in Wichita, TMC, and Lee Summit, and Health Partners in Olathe, we took that van there to give our shots, and we continue to do some follow-up visits at those vans. And Barb Pahood in my group is shown there in the picture on the top right inside the van. And anybody that knows Barb knows she's a pistol, and she really helped us get this study and get the team working. So these were the people that we were targeting. We are enrolled now, so we're no longer enrolling anybody else as a week ago Friday. But these were really our target. And I can tell you, when Moderna and Pfizer were rolling out their studies, they were using the usual mechanisms of doing studies and enrollment, and over 90% of their population were whites, were Caucasian, and we know that that's not the right thing, because if minorities are being disproportionately affected, you got to figure out, does it work? Does the vaccine work in minorities or not? And so we from the get-go had said we need to figure this out, and how we're going to not do that same thing. We wanted to know, is the vaccine safe first? We wanted to know, would it reduce the severity of, if you came down with COVID-19, would it reduce the severity of that illness? And then lastly, would it actually prevent infections itself? When we give a vaccine, we know that there are side effects. Anybody on this call that has gotten the flu shot, sometimes you develop a reaction to it. And these are the reactions that we know are related to the vaccine. So if you're out in the community and they ask you about the vaccine, I'm always very forthcoming with, yeah, there are side effects from it. Fever, chills, rash, aches and pains, nausea, headache. But these are all very brief. They usually last 24 hours and they're over the next day. They may last out to 72 hours, but usually they resolve. It's pretty rare in our studies where we've seen anything last out to a week, but it occasionally does happen, but it doesn't usually go much beyond a day or two. The other thing that's very common is pain, redness, and swelling at the injection site in your arm where you get the shot. And again, it's definitely a kick. People have said it's definitely more than the flu shot. But when you think about this compared to what I'm going to show you some pictures here with COVID-19 infection, this is nothing. This is nothing compared to a real life COVID-19 infection and how it can affect your body. There have been some serious allergic reactions, quite rare, about 1 in 10,000 it occurs. And therefore, when we give the shots in any setting, and in the community, at healthcare sites, you have to be able to treat those allergic reactions. And so again, it's a very important thing that this can't be done without that capacity to treat that allergic reaction. This is another story I want your help to convey to the community. We're not giving COVID to you with the vaccine. We have taken from the pieces of that COVID-19 protein that I showed you earlier. It's not the whole virus. Therefore, the vaccine cannot cause you to have COVID-19 illness. It's like taking, part of a bicycle and saying, go ride that bicycle. If I gave you the handlebars, right? You can't ride the bicycle. And so the same thing, we're giving part of that virus to stimulate your immune response to prevent infection. We're not giving you the coronavirus. Again, when we started to plan this last summer, we said, we need to do this right. So we partnered with Mariana, with Juntos. We partner with Broder Crawford at Embassy Community Development Corporation to help us get to the community and encourage them to use non-traditional spaces where we know that, people are working or people congregate, people get their information from. And so we were very fortunate to partner with Mariana and Broderick because they got us out there. We did several things on the radio. Barb and I did on TV as well, that really trying to get that message out there about the importance of us, one, participating in the studies, because that's how we're going to know if it impacts our communities, but also to convey factual information about COVID-19 to the community. I also want to mention that Radix Up is a new venture, and certainly Mariana can talk a little bit more about this, and Broderick. This is a joint venture between KU and between KU and our community. Myself, Dr. Greiner, Dr. Ellerbeck, and Broderick are all PIs, and we're leading this Radix Up venture. So this is to increase testing. And I think as, when we think about the vaccine coming out, one of the things we're very fearful about is that people say, well, I just need to get the vaccine. I don't need to worry about testing. And that's the wrong message to get out there, because testing is what allows us to understand spread of this disease. And if we don't have people going in for testing, we will not understand how to protect ourselves better. We won't understand efficacy of the vaccines itself, real life efficacy. So we have to encourage testing to be done as frequently and as often as possible in our minority populations. And Radix Up is focused on 10 different health counties. They're depicted here. And they've partnered with these action teams across the state of Kansas to allow us to increase testing capabilities within these counties. And certainly I want your all's help to get this message out there, the importance of going for testing whenever you have any symptoms or signs of COVID-19 infection, to make sure that you just are not a spreader of the disease itself. Carriers are a big problem for this. And as we get to the new variants with coronavirus, this is going to be even more of a problem, because these variants are very highly contagious in their spread. I just want to end with a little bit about COVID-19 and how it presents and treatment, because this is another story that I need to get out to the community, because we do have effective treatment now, but it has to be given early in the disease state. So the patient of ours on the left is relatively early. Their chest x-rays on the top panel, the CAT scan is on the bottom left panel. And you can see they have those gray shadows, those are pneumonia, but at early stages. The individual on the right, though, is at a much farther stage of the disease. They're on a ventilator. They have, you can see the ICU leads there, those, they're hooked up to monitors and so on, much more advanced. Once we get to that advanced stage in the hospital, we have very little treatment. It's all supportive treatment. But we need to identify the disease much earlier, even before the case on the left, in order for it to be effective. So what is the treatment that we have available? So right now there's only one drug that's fully approved by the FDA called remdesivir, which is an antiviral, and it has modest benefit. I've used it a lot in our hospital patients for the treatment of COVID-19 infection. It is not a miracle drug, though. It lessens the days of symptoms that you have, but it doesn't turn you around 100%. What has been amazing, though, is these antibodies. There are now 2 approved under emergency use authorization. This is what we refer to as an EUA. One made by Regeneron. This is the antibody cocktail that the president received when he came down with COVID-19. And then the one that is most often used in our community is the one made by Lilly that was released called banalimab. And don't ask me to say that 10 times, but I just prescribed this for a patient yesterday. We're doing it through infusions. And that infusion takes about 20 minutes to get in, but it definitely works. And now it's been approved. We were conducted some of the studies here at KU on this. We enrolled some patients with banalimab when it was early on in the treatment that led to this approval for it. But the story doesn't stop there because we have a long ways to go. And so we're studying a new monoclonal antibody cocktail. This one is called BRIE. This one might be better than the 2 that are approved because it's a combination. So the idea is that if you combine 2 different antibodies together, you might trick the virus, so that it doesn't, the virus doesn't develop resistance. And also this antibody lasts a lot longer in your body. So we think it might have some advantages over what is currently approved in the emergency use authorization. So what we need your help with is getting this information out to the community that if you're having symptoms of COVID-19 infection, get tested. If your test is positive, think about coming in for this study. You can contact myself or Luigi's numbers at the bottom there, 588-4022, 913-588-4022. And we will screen you over the phone and say, hey, come in, get the infusion at no cost. The infusion, in fact, we pay for your time and effort to participate because it is a research study. You do have to have these criteria. We have to capture your symptoms within 10 days, and we have to have your positive test within 7 days. So you just can't sit around with a positive test at home, wait till you get really sick and then come in. It doesn't work because by the time you come in and you're really sick, you need to go in the hospital, and this doesn't work in the hospital. This has to be early on in the disease when you're still having mild symptoms, and then it works. We've had patients call us after we were using that banalimab, the one available currently, and they said, all my fever went away 24 hours later, Dr. Castro. My muscle aches and everything, they all disappeared. And so it does work, but it has to be treated early on. And these are the criteria that are currently for this. I am excited that within the next week, we're likely going to expand this with another 5 treatments that we're studying. We're going to study an oral agent, an injection, instead of an infusion, just a simple IM injection, a nebulized treatment. And we're going to be studying all that as part of this active 2 trial. Luigi's contact will be the same there. But again, if we don't get people coming in from the community early on, we won't be able to figure this out. I think yep. So I just want to summarize, we are struggling ever from the beginning, from the get-go here. And this is, a lot of history is here because our communities in the past have been negatively impacted in terms of participation in research, but also just, how people have been treated with COVID-19. And certainly because this disproportionately affects minorities and racial and both ethnic minorities, it is something very important for us to convey that we are doing these studies at a very rapid pace, but we're doing them in the best possible way with the best science possible. The studies that I do for other treatments, for asthma and other things, are done the same way. We go through these 3 phases of development. These vaccines are in phase 3 right now, are enrolling, large number of participants for us to know, is it safe and effective? And so we're not cutting corners. Other countries have done that, unfortunately, and we're not doing that here in the US. We're studying these the right way. Unfortunately, to do it the right way, you have to have a placebo arm. So like when we enrolled patients here in Kansas City into that AstraZeneca trial, everyone I met with, I said, you have a 1 out of 3 chance that you will get placebo. And that means you're not getting the real thing. And you have to understand that. And I say, I'm sorry, but that's the only way I can tell if this is working or not, and if it's safe or not. And what we did tell them is after the vaccine gets approved, then the sponsor has told us that they will make that vaccine available to them for free. So it is something that, again, we're all in this together. And we all face these challenges of distrust. We face the challenges of disproportion and affecting our minority populations, but we need your help to overcome those challenges. So I'll end there and thank you, Miranda, for inviting me and helping me participate, and I'll leave time for questions. Thank you.
Absolutely. Thank you so much for that presentation. When I think back to the couple of presentations that I've sat in on for the COVID vaccine, I don't think we've had anything that was as plain language broken down for us who don't know all the medical terminology, as well as the behind the scenes information that you kind of gave us. So we really do appreciate that. So as far as questions go, we can go ahead and just, if you want to, call out or unmute yourself and then ask the question. Otherwise, you can utilize the chat feature as well. And then Carla will be monitoring that and we'll kind of go back and forth, whatever you're the most comfortable with.
Miranda, I'd like to ask a question. This is Broderick. So first, Dr. Castro, thank you for your presentation. As always, you do an outstanding job. What I'd like for you to address with this group is a myth. So there are a number of clients that many of us work with who think that if they have had COVID previously, that they are developing antibodies and so therefore will not need the vaccine. Can you speak to that and help us better understand what the science is behind that?
Yeah, so if you have a normal immune response, you will develop antibodies to the infection. The problem is the amount of those antibodies and the durability of those antibodies is unknown and is difficult at this point to measure. So I've had patients that have had previous chemotherapy and we measure their antibodies and it's 0, even though they have had a COVID infection. So you don't know what's going to happen. You could have had the COVID infection if it was positive and you knew that, but you may be susceptible within a relatively short time period. So what we recommend now is that as soon as you get out of quarantine, after you've had COVID infection, so that's 10 days, per the CDC guidelines, then you should get the vaccine. if you have it available, if you're one of those groups in the phase that can get access to the vaccine. And the reason is the vaccine will guarantee that you will have kind of that adequate level of protection. And whereas the natural infection does not guarantee that.
Thank you.
Thanks, brother.
Hi, this is Carla. One of the questions in the chat was, is this flyer available in Spanish? Or is there a flyer available in Spanish?
Mariana, you want to address that?
Yeah, absolutely. So for the treatment trial that Dr. Castro was talking about, we have a designated person who speaks Spanish. She's a native Spanish speaker, and she'll be happy to pre-screen people who are interested. And we also have materials in Spanish. If you're interested, you can put your email here in the chat, and I'll connect with you to get those materials to you.
Also share with the group that because Mariana and I are both participating and assisting, particularly more Mariana than myself, we have a communications group that has put together all types of communication materials, whether it's from wearing a mask to why to get vaccinated, any of those types of promotional materials, both in video, we have it in written form, that between the two of us, we'd be happy to get to y'all if you all are interested for your respective clients.
Yeah, thank you, Broderick. For either of those, feel free to reach. For the materials, feel free to reach to Broderick or I or myself, and then for the treatment, you can reach out to me, and I'm gonna put my email address here too.
Dr. Mario, this is Brian. I don't know if I missed it or not. Does it matter the legal status of the patients who could participate in your trial?
Great question, Ryan, and I didn't address that. So we have been very sensitive to that. So when we enroll participants, all we need is their name and date of birth. We don't need any federal documents. We don't need anything like that. We send that in. We need that information because we check for COVID-19 infection, and that has to be run in a lab. And so I have to put a real patient's name and ID on there because we can't create duplicate patients. So that's the only information we require to participate in the study. When we pay individuals, we've given them these credit cards called ClinPhone cards. So they get payment right into that credit card. We don't have to have a social security number or anything like that. So we were very careful in making sure that undocumented workers, undocumented individuals, migrants could participate in this study. And that's true for the vaccine trial as well as the treatment trials. We have those mechanisms in place.
Awesome. Thank you so much.
Sure.
This is Manuel Solano. I have a question, Dr. Castro, about the dioxychloroquine that, I don't know, in South America, a couple of presidents came out talking about drops as a cure for COVID-19. I don't know if you have seen that, but Latinx community, and I'm having calls asking, hey, does this work? Believe it or not, the president of Venezuela came out on TV saying that some drops, and they call that something specific, that they cure this. So we are getting calls asking, hey, can we use this? And that's something that I wonder if you can talk about. Sure.
Manuel, to be honest, I don't know specifics about that drop or that product. I suspect it's related to, it probably has some disinfecting kind of properties because of the fluorine. I would be concerned because we know this virus, once it gets into your nose, it can quickly spread down the respiratory tract, down the airway. And so if you use something topical up here, it may not get to where the virus is itself. So I don't know. We would have to find out more information about those drops, but I suspect that it's kind of like our prior president, a little bit of false news.
Thank you.
Dr. Castro, could you talk a little bit about whether people, once they have gotten the vaccine, they can be contagious to others?
Sure. Great question, Mariana. Yes, they can be contagious. So, kind of like I showed you in that picture where you make those antibodies and it blocks the binding of the virus. Well, the virus, you can still carry it around and you can infect other people. So it protects you, but it could be that you're carrying it. You become now a asymptomatic carrier. And so that's why we stress that even after you've gotten your vaccine, and as a healthcare worker, I've gotten the 2 shots, I still wear a mask every day I'm in public or taking care of patients, because I could be spreading it to my patients or to others in the community. And so we still got to do social distancing. We still got to do the mask. We still got to do the hand washing to stop the spread of the disease, even after you got the vaccine.
Hello, this is Treva Smith. My question has to do with that. A lot of people are concerned that they're still able to spread it. So what then would the benefit be to receive a vaccine that you can still spread?
Yeah, thanks.
I mean,
Great question. I mean, right, you still can spread it after you get a vaccine, but it won't attack you, right? So if you develop those antibodies, it can't bind and go inside your cells, and therefore you then are protected. So the vaccine helps you, and it will protect you from getting bad COVID-19. And I have had patients unfortunately die from this disease. The other thing is that at some point, and we don't know when that point's going to be, it might be next fall, we don't know. If we believe that if enough of the community out there is vaccinated, and we think that has to be somewhere between 60 to 70% of the population, then you have created what's called herd immunity, and therefore you will stop the spread of the disease itself. And that's what happened with polio. I mean, polio doesn't exist here in the US. And the reason is we develop herd immunity to that virus, and we stop the spread of it. But as you know, there are parts of the world, unfortunately, that still do have polio, and it's because there's not enough people vaccinated. So.
Thank you so much.
Sure.
Thank you. I have another question from the chat from Julio. What are some ways to talk with clients who do not trust the vaccine for various reasons? One of the reasons he says was that the vaccine was rushed.
Sure. Great question. And I don't know if I have any answers. You guys may have some answers as well. I tell them first that this vaccine is being evaluated just like any other treatment that we have. It's gone through all the scientific studies to get there. Even though we are under Operation Warp Speed and we are pushing it, but it's because this is a public health emergency, we have to push it. It is still being done the right way, being studied the right way. The other thing I tell them is I'm very frank about the side effects. I tell them what to expect, because people create distrust when people don't have that information. I got a shot, nobody told me what it was, and I got sick afterwards. I heard that a lot. And so you have to create that information is, this is a vaccine. When your body builds an immune, a protection with antibodies, it might make you have some side effects from the vaccine. I tell them that's a good thing. That means it's working, right? So creating that knowledge, that sharing that information to me is a second way that I try to overcome that distrust. And the third thing I mention is I need your help. I'm in the middle of an emergency, a public health emergency. I round on COVID patients in the hospital. Almost half of my patients are either African Americans or Hispanics. And I have some very sick patients on ventilators. I need your help to know how to fight this for our population. And, whether or not you're Black, you're purple, you're yellow, whatever, I don't care. I want to know, does it work? And for when I enroll them into a study, I said, I need your help, because if you're brown like me or Black like me or whatever, and I study it in enough people like us, then I'm going to know if it's working or not. And that is reassuring to me, because there are examples of medications that will have been studied in whites, shown it works. And then when you try to use it in Blacks, it doesn't work. So we need to know for this vaccine and for other treatments, does it work in the populations that are being affected? And so I asked for their help to participate. And I said, even if you got placebo, you're helping me. You're helping your grandchildren, if they're a grandparent. I said, you're helping your grandchildren, because they're facing this, over the next several years. So those are the three things that I do. But I'm welcome, because I learn all the time from others how they approach things and how do they create that trust message.
Dr. Castro, if you, one of the things that we have done, and I'm sure that you're aware of this, is that one, we example the behavior. So those of us like myself who've had the COVID vaccination, we filmed it, and so that we could share that with people that look like us, and so that they could see someone that they can identify with that has taken the vaccine. Mariana has done a great job with her communications team with at least 4 or 5 of us that are both African American and Latinx, who have taken the vaccine, and now those videos are available of us actually taking the vaccine. I will share with you all, even within my family, I have 6 brothers and sisters, and they tried to talk me out of getting the vaccine. That's how opposed they were. But now that I've gotten it and had minor, symptoms posted, and I have encouraged them to also talk with their physicians. In one case, I have a sister who talked to her physician, and her physician had gotten the vaccine, who's also African American. And so as we continue to identify those folks who understand the importance and value of being examples, if you will, of being champions for the cause, it then allows others, it decreases their distrust, because they see people that look like them that have successfully taken the vaccine.
And I agree with you, Broderick. I've had people tell me in the Latino community saying, well, how can I know if this is real? I've heard word by mouth. So they listen more to their to friends and families instead of actually looking at the science into it. So I know in this study, or Mario, what you're saying that you're needing help. Is there any way we can get testimonies from those that have participated, just so it can build trust, just like Broderick was saying?
Yeah, that's a great idea, and maybe Mariana and Broderick, I can get your help to build that messaging with participants in the study. Maggie, one of my coordinators, told me last week we had a participant that had 6 members in his household come down with COVID, and he didn't. And I said, well, I haven't unblinded you, but I wonder what you got. And so, this stuff works. It's amazing how effective it can be. So I do think we can create that messaging, and and share that with the community. I think that's important. And thanks for that link about Venezuela's president. Manuel, I appreciate that. I'm gonna share that with my colleagues so we can attack that misinformation.
And yeah, that is one. There is a lot of information coming from Bolivia, and it became very popular. They are selling the product a lot. So Bolsonaro from Brazil mentioned the same thing on TV. So those are some announcements that really concern me.
Yeah.
Alrighty. If there are no more questions, I'm going to stop the recording now.